talk in this session, which is from the University of California, San Diego, titled "The Impact of the COVID-19 Pandemic on Spine Surgery Practice and Outcomes in an Urban Healthcare System" by presenter Xiang. And you know Is my done? Yes.
Okay, cool. Hello everyone, my name is Selena, and today I will be discussing the impact of the COVID-19 pandemic on spine surgery practice and outcomes in an urban healthcare system. All authors have documented that they have no disclosures. The COVID-19 pandemic has greatly affected the way that hospitals prioritize their care. Due to the changing dynamics, there has been an emphasis on the type of surgical case, the risk status of the patient, and availability of resources, which are taken into consideration for providing quality care. Orthopedic surgery is especially interesting to look at, as many cases are elective and modifiable. For most elective or non-urgent cases, physicians have postponed operations following the new administrative guidelines. Sometimes, even patients in pain may choose not to come in due to fear of catching the virus. However, delaying surgery may be dangerous as it can result in longer recovery time, more complex surgery in the future. So most of the existing literature on this topic is focused on developing decision-making guidelines and determining which surgeries are essential to perform. But few have examined the influence of these new guidelines on patient outcomes. Therefore, the objective of our study is to elucidate the changes due to the COVID-19 pandemic in a cohort of spine surgery patients for patient demographics, surgical care, logistic and administrative aspects, and patient outcomes.
So your remote target is here.
Oh, okay, thank you. So our study population consists of 331 patients who had spine surgery at UCSD orthopedic surgery. Of these 331 patients, 185 had surgery prior to the COVID-19 pandemic between March 1st, 2019 and May 31st, 2019. The other 146 spine surgery patients had surgery during the first surge of the COVID-19 pandemic between March 1st, 2020 and May 31st, 2020. The variables we focused on were the demographics, risk factors, insurance, surgical data, operational data, and outcomes of patients. For demographics, we looked at patient age, gender, race, ethnicity, and BMI. For risk factors, we looked at ASA rating, smoking status, and diabetes status. Surgical data included the type of procedure, discharge disposition, underlying diagnosis, length of stay, and estimated blood loss. Operational data covered surgery time, recovery time, prep time, and follow-up care type and quality. So we looked at post-op visits at around 2 weeks, 6 weeks, and 3 months. Finally, outcomes data was based on complications and patient pain reported outcomes. Pain scores were taken at 4 main time frames: pre-op, discharge, short-term, which is within 4 months, and long-term, which is between 9 to 15 months. All complications within 90 days were recorded. Continuous variables were compared using independent t-tests between patient cohorts. Categorical and binary variables were compared using chi-square analyses. Looking at the table, there do not appear to be significant differences in demographics of spine surgery patients before and during COVID-19. However, there does appear to be a trend toward more Hispanic patients during COVID with a p-value of 0.074. In terms of risk factors, there are no differences in patient comorbidities before and during COVID-19. Just a little side note, ASA rating is an important risk factor as it assesses a patient's health and his or her ability to undergo surgery and anesthesia. The greater the number, the greater the risk. Next, for surgical data, one of the variables we focused on was the diagnosis. As shown in the pie chart, there's a significant increase in fracture cases during COVID-19 with a p-value less than 0.001. Additionally, during COVID, the hospital length of stay was reduced by around 4 days from an average of 10 days to 6 days and a p-value of 0.032. There was also a trend for a greater estimated blood loss during COVID-19 with a p-value of 0.064. Continuing with the surgical data, we also saw significant differences in procedure types before and during COVID-19. During COVID-19, there were more decompressions, foraminectomies, laminectomies, mastectomies, discectomies, and kyphoplasties. Meanwhile, the category of other decreased with a p-value of 0.05. And this category includes procedures such as tumor resection for cancer patients and corpectomies for severe scoliosis. Also, there was a significant increase in the number of procedures per surgery during COVID-19 with a p-value less than 0.001. Here's a table of the other surgical outcomes we recorded. As expected with the modified hospital guidelines, there were more urgent cases during COVID-19 with a p-value of 0.035. There were also fewer inpatient cases with a p-value less than 0.001, and there were fewer stage surgeries during COVID-19 with a p-value of 0.0. There was a trend for fewer stage surgeries during COVID-19 with a p-value of 0.072. For complications, there were fewer post-op complications within 90 days during COVID-19 with a p-value of 0.024. There were also fewer reoperations within 90 days during COVID-19 with a p-value less than 0.001 and a smaller 90-day readmission rate with a p-value of 0.039. For pain outcomes, long-term pain scores were not influenced by the COVID-19 pandemic. However, discharge day and short-term pain scores were higher. Discharge day pain scores increased from an average of 4.16 to 4.87 during COVID-19 with a p-value of 0.042. Short-term pain scores increased from an average of 3.62 to 4.33 with a p-value of 0.05. From our study, we found that there were no significant differences in demographic characteristics of spine surgery patients at UCSD before and during COVID-19. So this is contrary to prior literature, which suggests that minorities especially had less accessible care during the pandemic. What we found instead was a trend for a greater proportion of Hispanic patients. This may be because during COVID-19, people were more likely to require care for work-related injuries. In our geographic location, San Diego, there's a greater proportion of Hispanics working in jobs of higher occupational risk. Additionally, during COVID-19, the hospital administration wanted to create more room for ICU beds and prevent the spread of COVID. So they were hard on the clinical team to prioritize urgent cases over elective cases. This may explain why we saw a significant increase in urgent cases in our study. This may also be the reason for the decreased hospital length of stay, inpatient cases, and increased discharge day pain scores. Because the hospital was not as strict about recovering spine surgery patients during COVID-19, they were able to allow patients to leave sooner than they otherwise would have. Also, during this time, surgeons were under increased pressure. They were fitting more procedures into the same OR duration, which could be a cause for greater estimated blood loss. As for the increase in the number of procedures per surgery, one plausible reason could be that doctors want to reduce the number of days the patient would spend in the hospital if the procedures were spread across multiple days. Another could be to justify the need for surgery. By piling on multiple procedures into one surgery, it could be argued that the patient is in a condition bad enough to require this level of treatment or care. Finally, even though discharge day and short-term pain scores are higher, the average of both increased by less than 1 point. For a pain score, it's not considered clinically significant unless the difference is greater than 2 points, which it is not. It's important to note from this that while discharge day and short-term pain scores did increase and we did see a trend for greater estimated blood loss, there were surprisingly fewer post-op complications, reoperations, and readmissions within 90 days during COVID-19. It seems counterintuitive, but this can suggest 3 possibilities. 1, the modified hospital guidelines were effective and did not influence overall outcome, if not improving it. 2, patient selection bias. The surgeons were picking out healthier patients who could get out sooner for bed restriction. Or 3, patients did not want to come back to the hospital during COVID-19 because they were scared of catching the virus. So, as with any retrospective study, there are limitations. One of the biggest difficulties we came across was that some patients never came back to the UCSD hospital after surgery, so we didn't have their post-op data. This made the data more difficult to analyze since there were missing components. We had a similar difficulty with the pain scores. So for some post-op visits, patients either did not give a pain score or it was not charted. This was especially prevalent in the long-term pain scores, in which around 47% of patients in both the pre-COVID and COVID-19 groups did not have a pain score. It's also important to note that pain scores vary from patient to patient as everyone has different sensitivity to pain. So we did not see some of the differences we might have expected in this study, but I think that's because we studied the first surge of the COVID-19 pandemic, a time in which people were not quite yet familiar with the virus and did not take it as seriously. Future studies may want to look at the second and third surges of the COVID-19 pandemic, which may show greater change. In conclusion, it has been established that during the COVID-19 pandemic, there was a significant reduction in hospital length of stay, more cases were designated as urgent, there were more fracture cases, and there were more procedures done within a given surgery. Additionally, discharge day and short-term pain scores were higher, there were fewer post-op complications and reoperations within 90 days, and pain was not affected in the long term. That is all. Thank you so much for listening.
Thank you very much, Selena. Are there any questions in the room? Yes.
First of all, great job, Selena. I just had a question about what made you select to focus only on spine surgeries.
So right now, I guess our research team, we're mostly like, we've been working with the spine, and so I think like all different categories of surgery would have, I guess, different outcomes, but for spine surgery, a lot of it's elective, I guess, because people come in for back pain, but they've had it for like several years, so it's not as emergent as some other cases might be, so there would be a greater difference since it's more, I guess, not exactly optional, but you could postpone it.
Makes sense. Thank you.
Selena, was the overall volume of cases compared, did you show that in your data? Meaning that during the surge versus the pre-population that you've used as a control?
Could you repeat the question, please?
Was less surgery overall done?
Oh yeah, there was less surgery done during the
by a
pandemic.
significant percentage?
Yeah, because before the pandemic, there was 185 within those few months, and then during the pandemic, there was only 146.
Okay.
Yeah.
So you pointed out something very, very interesting. You know, during the first surge of the pandemic, at least here in the state of California, there were state guidelines around what could be done, and institutions implemented in different ways. So you noted in your population during the first surge that you had a decreased length of stay despite having an increased number of procedures. So was there a conscious change in how the surgery was done? I know you speculated on that in your conclusion slide, but what do you really think happened? Because that's impressive to cut the length of stay down by several days in the setting of doing more procedures.
Yeah, so I would say because there was more procedures done per surgery, but we also did not see an increase in OR time. The OR time was actually about the same in both groups. So we're thinking that they did work faster during the surgeries to reduce that time, and also, I guess, for the discharging criteria, they were able to allow patients to leave, I guess in some cases, sooner than they otherwise would have because they wanted to create more room for those ICU beds.
Gotcha. And it appears we have a question and a comment that came in on the chat. Was time to surgery examined? And wonderful job.
Oh, thank you. I don't think, like, what do you mean time to surgery? I guess.
I'm afraid I don't know. I assume, one of the interpretations would be from diagnosis to getting into the operating room, perhaps.
No, we did not look at that, unfortunately.
Great. Okay. Dr. Ober?
Yeah, fascinating. Also following up with what Dr. Gupta was saying, just interesting. You also had reduced complications and reoperations, and I'm curious if again do you have any idea if that is real, or is that something that is not being reported because people were scared to come back in, or are you feeling that that's a real benefit? If it is, we should have pandemics more often. But I'm curious if you can relate that. Is it quicker OR time so that you're doing more procedures and that reduces our risks? Or do you have an idea?
Yeah, that is a possibility. The other idea we were coming up with, I think you suggested it, it was that I guess patients, even if they are in pain, they might be scared to come in because the hospital, there's the fear of coronavirus and getting it, so they might have decided to wait it out longer. And we did focus on those complications within 90 days. So maybe with COVID, they felt like they could wait.
But that also includes infections and other types of complications, not just pain,
Yeah.
correct?
Mm-hmm. So then that did improve, yeah.
I think that's remarkable.
We found it really interesting too. We're not quite sure exactly what caused it.
Maybe it was the extra PPE we were.
Well, what influenza would have done, right?
Right.
Yeah, so.
Super, thank you very much.
Thank you so much.